joining today's virtual educational program with Cancer Support Community Los Angeles. I am Larissa Montalvo, and I welcome you to this week's webinar titled Blood and Immune System Related Cancers. Today, we will be joined by Dr. Leslie Popplewell, Associate Professor at City of Hope's Toni Stephenson Lymphoma Center, to review the behavior, diagnosis, and treatment of hematologic malignancies, including blood and immune system related cancers. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about our services or watch our past webinars, please visit our website at www.cancersupportla.org. Without further ado, I would like to welcome today's speaker. An associate professor at City of Hope's Toni Stephenson Lymphoma Center, Dr. Leslie Popplewell is the principal investigator for a number of clinical trials examining new lymphoma therapies. She's also working on advanced transplant techniques for patients whose lymphoma has recurred. Dr. Popplewell received her medical degree from the University of Louisville School of Medicine. She joined City of Hope in 1998 following a fellowship at the renowned Memorial Sloan Kettering Cancer Center in New York City. Welcome, Dr. Popplewell.
Okay, thank you very much. I hope that you'll find the next hour or so interesting and informative, and I really appreciate your attention today. I know it's been a difficult year, a difficult time, and it's always difficult dealing with an illness or having a family member who's dealing with an illness, but this has been a particularly difficult year. So I'm going to take the next 45 minutes or so to talk a little bit about blood-related cancers, and those would include things like leukemia, lymphoma, and multiple myeloma. I'm chief of the division of lymphoma at City of Hope, and so I work very closely with my lymphoma disease team, but I'll be also talking about leukemias and myelomas today. And I'll try and leave enough time at the end if there are some specific questions that we can answer for you. I'm going to try and share my screen today. I practiced doing this once, so let's see how that works. So I've got that, and then I'm going to go to the slideshow presentation mode, and I hope that you can see what I'm showing on my screen here. I'm just going to go ahead with this. So aims of the session today, I just want to do a brief overview of the hematologic system, that is of the blood making system. And the reason for going over that is really just to show you where the malignancies develop. A lot of our understanding of the behavior of these kind of diseases, as well as the treatment for the diseases, hinges on when in the development of blood cells the malignancies occur. So again, we'll talk about leukemias, lymphomas, and myelomas and other related illnesses. I'm going to go ahead and just go through this. This is a little kind of a busy slide, but at the top of the slide, you can see up here what we call a multipotent hematopoietic stem cell. And so these stem cells are cells that eventually can form all the different kinds of blood cells in our bodies, including red cells that carry oxygen, platelets that help us clot our blood if we cut ourselves, and also all of the different kind of immune cells. And so when you hear about stem cell research and stem cells, often we think about those cells that can develop into any kind of cell in the body, including skin cells, bone cells, etc. So what we're talking about here are really just the cells that can develop into blood cells. And so when I talk later at this hour about stem cell transplant, this is the kind of cell that I'm talking about. This is the kind of cell that we collect and that we then give back later to the patient. So these multipotent stem cells first develop into either a common myeloid or a common lymphoid progenitor. And then they go through a series of steps where they become much more mature. And at every step along the way, they become a little bit more specialized and a little bit more functional. Um, Hematologic malignancies, or the process of transforming into a cancer, can occur at various different stages. And so what tends to happen is that the very early acute leukemias will develop way up here in the myeloblast stage, and in this area. And then the very early, more aggressive lymphoid malignancies will develop up here in the lymphoblast and pro-lymphoblast stage. So where the cell becomes malignant is where the cell kind of gets stuck, and that often will dictate the aggressiveness of the disease. So we'll talk about that more as we go along. And I want to continue. Here we go. And just talk a little bit in general about acute leukemias. Acute leukemias are a broad category of hematologic malignancies, but they're very aggressive, and typically patients will come in with some pretty severe symptoms that may have developed over a very short period of time. And these are really emergencies. We don't wait to treat these patients. Generally, they require hospital admission right away. We jump into action. We begin the diagnostic workup for these patients, and our goal is to get them as quickly to definitive therapy as we possibly can. So I know at my institution and many others, you've heard of a code blue, where you take a patient who's having trouble breathing or having heart troubles. We have something called a code acute leukemia, where when we hear this is happening, we jump into action. When we get a referral from a referring doctor, we try to get the patient in immediately to our hospital without delay. These acute leukemias tend to be very sensitive to chemotherapy, which is good news. And really the best initial test is looking at the peripheral blood smear, because a lot of the abnormal cells are usually circulating around in the peripheral blood. We can do a lot of diagnostic work on just peripheral blood alone. The white blood cell count, remember, this is a kind of cancer of the white blood cell cell group. The white blood cell count can be low or normal or high, depending on the circumstance. Patients often will come in with symptoms of anemia, meaning their red cells are low, because they've really crowded all the normal blood-making cells out of the bone marrow. So they're not really able to make enough red cells, which means they may be tired, they may be getting short of breath with just normal activities. Because we have a lot of non-functional, very immature white blood cells, these patients are very susceptible to infections, and patients may have had recurrent infections over a short period of time. Because they don't make platelets the way they should, they may have bleeding issues. And some patients have both bleeding and clotting issues depending on the subtype of leukemia. So what I put together here was a look at bone marrow in a normal versus an acute leukemia kind of a picture. And what we see here on the left is a peripheral blood smear. And so when you take a drop of blood and you put it on a glass slide, you'll often see little red blood cells. These are pretty normal looking red blood cells. They're carrying oxygen. But these white blood cells are really abnormal looking, and I have a normal one later in the presentation to show you the difference. But these are really very big white blood cells. The nucleus of the cell, this purple area, is huge. The chromatin, the chromosomes are very open. So this is a very metabolically active cell. And if we look at the normal bone marrow versus the AML bone marrow, you see a whole wide variety of different sizes and shapes and configurations of cells here on the left. And then over on the right, it's just very monomorphic. It's just the same cell over and over. It's like someone took a copy and pasted all these different cells here. And that's really what leukemia is. It's one cell out of control, making more and more of itself and crowding out the normal looking blood cells. This is another look at the picture of the blood cell development. I just wanted to bring to your attention that I'm going to talk a little bit also about the chronic leukemias, and the chronic leukemias tend to occur down here in this area with the more mature cells. So chronic leukemias are a little bit different, and patients may present with a much longer lead time. Often these patients are diagnosed when they come in for a routine checkup, and maybe they're not really having symptoms, but their primary care doctor looks at a blood count and notices that it's a little bit abnormal. And maybe the white blood cell count is a little bit high, and maybe it was not quite as high at the last visit. But over time, one can see that the white count is really going up and up slowly. So that's how these patients present. They're much less likely to present with low blood counts, with severe anemia. They're not likely to present with very low platelet counts. Sometimes we don't treat these patients right away. We don't really consider this an emergency the way we might consider an acute leukemia presentation. So these patients may do very well even without treatment for a number of years. Because the cells are more mature, they tend to be less sensitive to chemotherapy than the acute leukemias. And again, the best initial test for this is usually a full blood count, followed by a bone marrow biopsy. And this is just a look at two of the different kinds of chronic leukemias that we have. On the left over here, I don't know if you can see my pointer, but on the left here, you can see this is a CLL patient, chronic lymphocytic leukemia. And you can see that in addition to all the little red cells here, there are white blood cells that are not very much bigger than the red cells, but they have great big nuclei here. And you can see that there are multiple of the same looking kind of cell. And on the right on this picture, this is a picture of chronic myeloid leukemia, or CML. And you can see a lot of much more mature looking myeloid cells. These are neutrophils and bands and a few other slightly more immature cells. So these patients tend to have an elevated white blood cell count when they're diagnosed. So in terms of classification of leukemias, we first look at whether they're acute or chronic, right? And this has to do with the way they develop symptoms, whether they develop severe symptoms early on, or whether those symptoms are slower to progress. And it also influences whether patients are diagnosed early or late in their course of disease. The other way we classify these leukemias is whether they belong to the lymphoid or the myeloid line. And remember, when we looked at our table here earlier, we started out with the myeloid progenitor and then the lymphoid progenitor. So the CMLs are down here, the CLLs are down here, the acute myeloid leukemias are up here, and the acute lymphoid leukemias are up here. So in each case, it's really growth of progenitor cells in the bone marrow that results in the replacement of normal blood-making cells, and ultimately results in failure of the bone marrow to behave properly. And so I put two pictures of bone marrows on here. If some of you may have had a bone marrow biopsy before, or you may have spoken to someone who had a bone marrow biopsy, in addition to collecting peripheral blood, we'll often do a bone marrow biopsy. And that's really taking a needle and taking a small core of bone marrow out. And once that's done, we can send that bone marrow off for tests. And we'll slice it into very thin slices and then stain it. And so what you're seeing here on the left is a normal bone marrow specimen. And you can see there's a variety of different kind of cells in here, these bigger cells. Maybe if I point over here, you'd be able to see it better. These bigger cells are platelets. These big white dots here are globules of fat. And so having some fat in the marrow is very normal. The older we are, the more fat we have in our marrow. So someone who's a child will have a much more cellular marrow, and someone who's in their 60s or 70s or 80s would have a lot more fat globules in their marrow. But in either case, you can see there's a good heterogeneity here. On the right, this is a bone marrow that's affected by acute leukemia. And you can see this marrow is packed. These are the little spicules of bone that are inside the marrow, but right up against it and stretching as far away as we can see, it's just packed and packed with a lot of cells. And those are all abnormal cells. So we want to use our treatment to clear away all that abnormal activity. So in terms of acute leukemias, risk factors for acute leukemias, most of the time we have to tell people we really don't know why you developed an acute leukemia, but we do know of a few risk factors. One of them is having had another cancer diagnosis previously and having had cytotoxic chemotherapy. And so it's very rare, but occasionally people who are treated with chemotherapy for breast cancer or for colon cancer or for anything else who receives cytotoxic chemotherapy can have some bone marrow damage, and this can put them at risk for having secondary malignancies like leukemia. And so that's one of the reasons why people who have a cancer diagnosis are followed long-term for their cancer, right? Not just because they might still have a recurrence of their cancer, but because we're looking for long-term consequences of some of their cancer therapy. So previous chemotherapy is a risk factor for acute leukemia, as well as for myeloid dysplasia. And there are also some inherited problems that can predispose people to acute leukemias. And those are a category of inherited problems called DNA repair defects. There are patients who have immune defects. And there are other symptoms or other problems like Down syndrome, which may also increase the risk over the lifetime of getting an acute leukemia. The common kind of tests that we do for a patient who's diagnosed with leukemia might include things like chest x-rays and CT scans. For CT, we're looking for whether or not they might have an enlarged set of lymph nodes in the middle of the chest. We're looking at whether or not there are abnormalities of the bones. We often will do a bone marrow biopsy, and on that bone marrow, and I just described it to you earlier, but you can see here a patient laying on their side getting a bone marrow biopsy. We'll send off that tissue not just for morphology to see the picture that we saw earlier, but we'll send it off for a test called flow cytometry, which is where we'll put those cells through a machine that will analyze the little proteins that are on the surface of those cells. We'll look at cytogenetics, and that's examining the chromosomes of the acute leukemia cells, and we'll do something called immunohistochemistry as well. The peripheral blood is collected, and of course, looking at the blood counts is very important. If we just look at that drop of blood under the microscope, we can learn an awful lot about what's going on in the bone marrow. In addition to the blood counts, we're also looking at the chemistries because we want to see what is the liver doing, what are the kidneys doing, how is the blood clotting system doing, is there an elevation of an enzyme called lactate dehydrogenase that can tell us a little bit more about the activity of the leukemia. And we're also looking at something called uric acid, which is basically a waste product that develops when we start treating the acute leukemias. We may also send off blood for a blood culture if we suspect that patients may have an infection, which is very common with acute leukemias. So I'll digress a little bit and start talking about specific kinds of acute leukemia. Acute lymphoblastic leukemia, or ALL, is relatively rare, about 1 in 50,000. are diagnosed. It's a slight male predominance, so men are slightly more likely than women to develop this. It is the most common type of childhood leukemia, and sorry about that, comprises about 70% of all the childhood leukemias, and it peaks at age 2 to 5, but later, after the age of 50, we start seeing more ALLs again. And again, why ALL develops is generally not known, but we do know that in the course of maturation, those white blood cells may develop genetic mistakes. And so sometimes two critical genes that aren't supposed to be attached to each other will suddenly become fused together. And suddenly genes that are supposed to behave in one way are starting to behave in a very different way. And so this is a look at the TEL-AML1 fusion can result in a predisposition for leukemia. AML, or acute myeloid leukemia, is also very rare. The incidence in the United States is about 3.7 out of every 100,000 people. It also has a slight male predominance. But in terms of adult leukemia, it's definitely the most common subtype of acute leukemia. And it can occur at any age, but the older we are, the more likely we are to develop an AML, and the median age at diagnosis is age 70. And so this tells us a lot about what we're able to do, because as you know, the older a patient is, sometimes the less they're able to tolerate really aggressive treatments. And so when we start talking to people about how we're planning to treat their leukemia, we know that a lot of that is influenced by how healthy their body is otherwise. Again, pathophysiology not always known, but often it takes an initial mutation followed by a second mutation in order to lead to a full-blown acute myeloid leukemia. And findings specific for AML would include mostly changes in the blood counts. So patients often will have some degree of anemia. It's usually fairly severe. So I've seen patients, a normal hemoglobin is, say, around 14 grams. I've seen patients walk into the emergency room with hemoglobin of 3 or 4 grams. Sometimes if the anemia develops over a long period of time, it can be very severe before a patient presents. White blood cell count is usually quite high, but if you have a packed marrow and there's nothing coming out of it, you could also have a low white blood cell count. Patients can also have blood clotting problems. Typically, patients don't have enlarged lymph nodes, but they can have collections of acute leukemia cells called chloromas, which are rare, but we definitely see them from time to time. And patients can also have skin involvement, and this up here is a little skin nodule, and we call this leukemia cutis. So occasionally we'll make a diagnosis of leukemia just based on a skin biopsy. In terms of treatment of acute leukemia, so we have both supportive care and interventional care. And so supportive care for acute leukemia often will include transfusion of blood products. We know that patients who walk in with very low red blood cell counts often will need transfusion of packed red blood cells. They will sometimes need transfusion of platelets if their platelets are very low and they're at risk of bleeding. We also have replacements of some of the clotting factors that are sometimes missing from the blood and in the form of fresh frozen plasma or cryoprecipitate. Infection is an incredibly difficult problem to sometimes deal with acute leukemia, just because there is really no functional immune system, and so antibiotic choices are very important. We talk about reverse barrier nursing. What that really means is we want to protect the patients from getting infection from other people. And so today, during the pandemic, we're all kind of acting like cancer patients because everyone's wearing a mask everywhere they go, which is a very good practice. for our leukemia patients. And so when a patient is in our hospital, any person in the hematology floor, before you walk into that patient's room, you clean your hands, you put on a face mask, and you put on a pair of gloves. And now in the age of COVID, you'll put on your eye protection as well. Tumor lysis syndrome is a problem that can develop when we begin to treat acute leukemia or lymphoma. And remember, we talked about uric acid as being a waste product of leukemia and lymphoma treatment. So the uric acid level can go way up and can cause kidney problems. And occasionally we'll find abnormal cells not only in the blood and not only in the bone marrow, but also in the brain and in the spinal fluid that surrounds the brain. And so occasionally doing a test called a lumbar puncture becomes necessary, and we can even sometimes give treatments of chemotherapy into the spinal fluid. This is just a look at a patient's kidneys. We have the tumor cells when they break up, when they're successfully treated, will often release things like potassium, which can have an effect on the heart. It can release uric acid, which can clog up the kidneys and cause problems there. It can cause changes in blood calcium level, et cetera. And so when we admit a patient to the hospital and we start treating their leukemia, we're very careful to give them special medicines to prevent all of this from happening. And we're giving a lot of IV hydration to keep their kidneys healthy. The definitive treatment for acute leukemia will include chemotherapy. And so induction chemotherapy often takes place over a period of 4 to 6 weeks. We generally will follow that up with something called consolidation chemotherapy, which is meant to really just get rid of whatever last few cells might have remained from the induction chemotherapy. And in the case of ALL, we often will put the patients on a maintenance therapy with low doses of chemotherapy for 1 to 2 years, because we know that helps to prevent the leukemia from coming back. There are a few additional interventions. There's a medication called all-trans retinoic acid, or ATRA, that we use in a particular subtype of AML during induction. Some of our newer treatments are monoclonal antibodies. We will sometimes incorporate radiation in our treatment of patients with acute leukemia. And I'm not really going to talk very much about bone marrow or stem cell transplant today, but that is certainly a component of treatment these days for acute leukemias, as well as for some lymphomas and myelomas. We also now have CAR T-cell therapy that's recently been approved, and so we can maybe talk about that at the end. But my point is that over time, there are more and more exciting new treatments available for blood-related cancers. And so when we talk about the prognosis of acute leukemia, I just wanted to bring your attention to this line here, which looks at people between the ages of 50 and 59, and we can see for AML at least, according to the year of diagnosis, the further out we go, the better the survivals are. And so children tend to have a much better outcome when we treat acute leukemia than adults do. Part of that is because children just seem to be able to handle aggressive treatment much better than adults do. But also, we think there's something that's somewhat different about the behavior of acute leukemias in adults. And so I will also say that over the years in the United States, there has been a much more concerted effort to try and treat children with acute leukemia on clinical trials. And I think that making sure that those clinical trials are available has really pushed forward the progress of success in that patient population. So children in the United States are far more likely to be treated on a clinical trial than adults are, which is really unfortunate. And I think that if we would concentrate more on that for our adult population, we'd probably make faster progress for the adults as well. Chronic leukemias are a different kettle of fish. Most of the CLL patients have a B cell subtype of lymphoma. The incidence is significantly higher than with acute lymphoblastic leukemia. It's the most common form of leukemia in the Western world, and it tends to occur much more often in people who are older rather than younger. And it's interesting that there is a familial version of CLL as well. So occasionally you'll have a CLL patient with a strong family history of that. The findings that are specifically for CLL usually include enlarged lymph nodes, high white blood cell count. Occasionally, they will transform to a more aggressive form of disease, and we call that a Richter's syndrome. CML, or chronic myeloid leukemia, the incidence is pretty low, 0.6 to 2 per 100,000. It can occur at any age, but it's rare in children and most often between the ages of 40 and 60. And CML is really one of the first diseases that we were able to link a specific chromosomal translocation to development of disease. And so with CML, we have this really unusual juxtaposition of two genes that shouldn't be next to each other, but in this case, they are formed. They form a new fusion protein when this chromosomal translocation occurs. And so finding that chromosomal translocation is really the way that we make that diagnosis. It's usually asymptomatic early on. It can cause enlarged spleen and generally causes the red cells in the to be low, and occasionally it can affect the platelet count as well. Treatment often for CLL includes watchful waiting with regular monitoring, but later on we often will treat with chemotherapy. There are new orally available drugs that are now very effective. And so I'm thinking of a group of medications called BTK inhibitors, like ibrutinib. There's also another oral medication that's available called venetoclax. And so it's exciting now to be able to offer basically chemotherapy-free treatments for CLL and some other kinds of leukemia and lymphoma. CML has another kind of oral medication, and this is the cover of Time magazine from 2001. And I was early on in my career when this Time magazine was published. But imatinib was a new oral drug at that time, which really completely changed the way we treated CML. And before 2001, our bone marrow transplant ward had quite a few patients with CML who were going through allogeneic bone marrow transplantation. And it seems like almost overnight, we had no CML patients in the hospital, or very few, because this oral drug was working so well. So there's a lot of progress being made these days. I'm going to skip ahead a little bit because I feel like we're already almost a half hour into this presentation, and I really would like to spend more time talking about the lymphomas and the myelomas. So I'm going to skip ahead and talk a little bit about lymphomas here. Lymphoma, as you may know, comes in two main flavors. One is classical Hodgkin lymphoma, or Hodgkin's disease, you might hear it called, and another one is called non-Hodgkin's lymphoma. And non-Hodgkin's lymphoma is really a broad category of more than 60 different subtypes of lymphoma. The cause of non-Hodgkin lymphoma is unknown for most people. There is a small percentage of patients with lymphoma who have an inherited form of the disease. We think that there are certain chemicals that may increase the risk of lymphoma, and that includes certain pesticides and herbicides. We also know that people who have been exposed to radiation may be at risk for that kind of disease. We also know that people who have an immune deficiency are at risk for lymphoma. And so patients with HIV, are at risk for aggressive non-Hodgkin lymphomas as well as Hodgkin's disease. And patients who have had organ transplants like heart transplant or kidney transplant who are on chronic immunosuppressive medications are at higher risk of lymphomas as well. Certain viral and bacterial infections can also predispose patients to lymphoma. And so the HTLV1 virus can predispose to T-cell lymphomas. Epstein-Barr virus can predispose to classical Hodgkin lymphoma. And H. pylori is a kind of bacteria found in the stomach that can predispose to gastric lymphoma. Most patients who are diagnosed with a non-Hodgkin lymphoma will present with enlarged, painless lymph nodes, but about 20% of patients will have other general symptoms, and that might include unexplained weight loss. It might include unexplained fever, unusual sweating at night, severe fatigue, and even usually with Hodgkin lymphoma, severe itching. And all of this has to do with substances and little hormones that the lymphoma can produce. I think we talked about this already in terms of what can predispose to a non-Hodgkin lymphoma, but I'll add to that list autoimmune diseases like lupus, like rheumatoid arthritis, and things like Sjogren's syndrome can increase the risk for a lymphoma. We also like to take an occupational history because there are certain agricultural pesticides and Agent Orange that have been implicated in the development of non-Hodgkin lymphoma. So I always ask patients, if they're in that age group, whether they had been in the Army, whether they had been in Vietnam years ago, because that's a recognized risk factor. There are also some other specific illnesses like Crohn's disease and celiac disease that can increase the risk for lymphoma. This is just a look at different locations in the body where lymph nodes occur. Some of them are areas that are easy to find, like in the neck and under the arms, but there are also lymph nodes deep in the body that we really can't feel with our hands and really require imaging studies like CT scans or PET scans to see. Lymphocytes come from, we talked earlier about the stem cells and the lymphoid progenitors, but as they go on in their maturation steps, they develop into T cells versus B cells. There are more B cell lymphomas, 85%, as compared to T cell lymphomas, but they're treated a little bit differently, and so that's important to know about. T cell lymphomas can include very immature T cells, which would create an acute lymphoblastic leukemia kind of a picture, or they can be mature T cells, and that can lead to things like peripheral T cell lymphoma, cutaneous or skin-based T cell lymphomas, etc. B cell malignancies can also occur at all stages of B cell development. And so B cell lymphomas tend to develop from mature B cells. And as that development continues further, those cells can develop into plasma cells. And when those become malignant, that's where we get diagnoses like multiple myeloma. And I'm going to talk about that at the end of my talk here. In terms of the relative frequencies of the different kinds of lymphoma, far and away follicular non-Hodgkin lymphoma and diffuse large B-cell lymphoma are the most common, and the others take up a much smaller portion of the pie. But it's important to realize that there are very different treatments for all of the different components of this pie. The way that we make a diagnosis of non-Hodgkin lymphoma is with tissue. And unlike with acute leukemia, where a lot of those abnormal cells are usually circulating around in the peripheral blood, with lymphoma, that's usually not the case. And so we need to get some kind of a biopsy. The pathologists who make these diagnoses, they're our colleagues They usually like to have more tissue so they can see sort of the architecture of a lymph node. So if they can get a whole lymph node that's been removed by a surgeon, they prefer that. But often we'll make diagnoses based on CT-guided needle biopsies. That's a little bit nicer for the patient. We talked about bone marrow biopsies earlier on. We often will perform a lumbar puncture looking for lymphoma cells in the spinal fluid. We draw blood for laboratory tests, including all of the ones that I talked about before with acute leukemias, and then imaging studies. CT scans, MRIs, and PET scans are very helpful. Factors that influence the treatment of the kind of lymphoma that you have has a great deal to do with the subtype of lymphoma and the stage of disease. We also look at whether the lymphoma is indolent or aggressive. We look at the prognostic index score of the patient. We look at whether they have lymph node, areas of the body outside of lymph nodes that are involved. We look at their age. We look at their other disease processes and the presence of symptoms. And we tend to categorize, just because there are so many different kinds of lymphoma, we categorize them into indolent versus aggressive versus very aggressive. And so the very aggressive lymphomas include ththings like Burkitt's lymphoma and plasma cell leukemia. The aggressive ones include diffuse large B-cell lymphoma. That's probably the best example. That's the one of the more common. And then the indolent lymphomas include follicular lymphoma, but might also include marginal zone or Waldenstrom's macroglobulinemia. And we talk about CLL and SLL as being sort of a spectrum of disease. When we stage lymphoma, we look at whether the lymphoma is very localized to a small group of lymph nodes, or whether it might include multiple groups of lymph nodes, as opposed to whether we have lymph nodes both above the diaphragm and below the diaphragm, or whether it might include things like bone marrow or solid organs. Treatment for lymphoma often includes chemotherapy. We also have monoclonal antibody therapy that we usually will combine with that. And I think that it's probably too complicated today to get too much into the different kinds of chemotherapy that we use. Patients who relapse are often treated with autologous stem cell transplantation, meaning we will collect some of their good, healthy stem cells and then freeze those stem cells down while we bring the patient into the hospital for high-dose chemotherapy, and then give them their healthy stem cells back. Occasionally, with leukemia or with lymphoma, we'll take stem cells from a healthy individual, like a brother, sister, and we will give those alternative stem cells to the patient. And that results in being sure that you have a clean product. Those new cells are better at combating cancer than the patient's own immune system, and we can escalate doses very well without toxicity to the stem cell component. And then finally, I wanted to just talk a little bit about multiple myeloma, and we call this group of disorders paraproteinemias, because all of these diseases can produce abnormal proteins that can accumulate in the body and cause problems. And so the most common of these that you probably have heard of is called multiple myeloma. There's another called monoclonal gammopathy of undetermined significance, which is sort of a precursor to multiple myeloma. And then there's one that's just really on the borderline between lymphoma and myeloma, and that's called Waldenstrom's macroglobulinemia. Why do people get myeloma? Again, our most common answer is we really don't know, but we suspect that exposure to radiation or to agents like benzene or pesticides might have some contributing factors. About 4 per 100,000 people in the United States are diagnosed with myeloma each year. The median age is 66. And patients often will present with things like elevated calcium levels in the blood. They may present with kidney impairment because those abnormal proteins are interfering with kidney function. They may present with low red blood cell count called anemia. They may present with lytic lesions in their bones or even pathologic fractures of their bones. They may have thickening of the blood called hyperviscosity. They may have areas where there has been deposition of that abnormal protein in the heart and elsewhere, and we call that amyloidosis. They may also have recurrent infections. The good news is that although we don't know yet whether we're able to really cure myeloma, the outcome is getting better and better. And what you see here is survival over from the 1960s through the 2020s has been getting better with each subsequent development of new treatments. And so probably the most interesting thing that's coming along recently are development of not just monoclonal antibodies, but development of CAR T cells, which were just recently approved for multiple myeloma, as well as bispecific antibodies. And so these are very effective new treatments for multiple myeloma. And so survival has really improved dramatically in the last couple of decades, and I think it will continue to do so. I mentioned that there's this precursor to myeloma called monoclonal gammopathy of undetermined significance. It's kind of a long name, and it means exactly what it says, undetermined significance. We really don't know why people have this. Most people don't develop multiple myeloma, but some of them do. It's often discovered incidentally in older patients. And it's not really considered to be a malignancy, although it can be a precursor to that. So these patients have low levels of monoclonal protein. They have fewer than 10% plasma cells in the marrow, and they don't have end organ involvement like the bone lesions and the kidney failure. But 1% of them per year do develop multiple myeloma. And I just want to end my portion of the prepared talk today with a picture of some of our cancer survivors. This is from our bone marrow transplant celebration that we have every year. And all of our patients are invited to come back, and you can see that everybody in this picture has a big button on their chest, and they're invited to put on there how many years it has been since their bone marrow transplant. So I'm gonna stop there, and I think I should stop sharing my slides at this point, and go to the option for the question and answer. And I hope I see there are a few questions in here already. So I think our host is probably on with us, and I don't know if you want to participate, but I'm just going to look at the questions here.
You're welcome to read questions that you would like to answer, or I can read them for you. Either way.
Oh, okay. Yeah, why don't you, well, let's just look at the first one here. It says, some of us are worried that blood cancer patients don't develop antibodies when they get the COVID-19 vaccine. Yeah, so I agree. And you mentioned that there's an article from Israeli research. Yes, absolutely. That's a concern. I think there was an article in the New York Times just this week talking about that. So our guide for our cancer patients is to continue to maintain as much caution as possible. Some of our cancer patients, our lymphoma patients in particular, are getting monoclonal antibody therapies like rituximab, which can really hamper the body's ability to make antibodies. And so for patients who are on rituximab containing therapy, we recommend you wait 90 days after your last dose of rituximab to get a COVID-19 vaccine. Our patients who had CAR T-cell therapy or stem cell transplant also, we'd prefer if you wait 90 days after to get the vaccine, not because we think the vaccine's dangerous, but because we think you have a better chance of developing antibodies after the COVID-19 vaccine. But I'll tell you, we don't know everything there is to know about COVID-19. And of course, the vaccines that are available right now were developed in, they were tested on healthy people, right? They weren't tested on cancer patients. So we don't know a lot about that. So there are a number of studies that are ongoing right now looking at COVID-19 and cancer patients and how well the vaccine works and whether there are tweaks to the vaccine that might be useful for those patients. So if you ask your doctor and your doctor seems unsure, it's probably because he or she is. We just don't have all the answers. I think that answers the second question as well. Plasmablastic lymphoma. So I see a question about that. Yeah, so plasmablastic lymphoma certainly is a rare and very aggressive form of non-Hodgkin lymphoma. I think there's not a great deal of consensus about the best approach, but we tend to mirror the kind of treatments that are currently used for diffuse large B-cell lymphoma. I think, it probably would make a lot of sense to go to a tertiary care center or a dedicated comprehensive cancer center for treatment of something like plasmablastic lymphoma, because it is so unusual and not every general oncologist out there has had the opportunity to observe very many cases. Yeah, and then the last question I see is that, again, about COVID vaccine. I know it's such a touchy area, and we're all so concerned about it. I mean, certainly we've seen our patients get infections. I've seen some of my lymphoma patients recover very nicely from COVID, and I've seen some have a really hard time with having repeatedly positive tests over a long period of time. So we do want to get our patients vaccinated as quickly as possible, but we don't know what to tell them about how effective the COVID vaccine will be for them. And then I see a question about aplastic anemia. So I didn't talk really about aplastic anemia, but it is certainly a diagnosis that we treat. Aplastic anemia is really, we don't think of it as a malignancy, but it's more of a bone marrow failure syndrome. And aplastic anemia, basically we treat with intravenous immunoglobulin and sometimes cyclophosphamide. Sometimes patients can resume manufacture of blood cells just with that kind of intervention, but often those patients will need a bone marrow transplant. Just to replace their bone marrow with functioning cells. But we have seen some patients with aplastic anemia later develop something like a myelodysplastic syndrome or even an acute leukemia. So there seems to be a spectrum there of aplastic anemia, and there's probably some interplay between the abnormal cells that can predispose a small percentage of them to actual malignancy. And then there's a question of points about MPN. And so I think you're referring to myeloproliferative neoplasms. And I didn't get into that very much just because of the time constraints, but myeloproliferative neoplasms would include things like polycythemia vera. It would include things like essential thrombocytosis. So those are malignancies where the cell that becomes malignant is pretty far down the chain. And so in the case of polycythemia, it's the cells that are producing the red cells that become malignant. With essential thrombocytosis, it's the cells that are producing platelets that become malignant. And so bone blood clots and other problems. So we often will intervene with orally available medications for those, but chemotherapy and bone marrow transplant are certainly used for patients with essential thrombocytosis, or ET, that then develops into more of a leukemic picture. And then I see another question: if the lactate dehydrogenase count is in the 500s, but all other labs are normal, does that indicate anything in particular? So that's a good question. It depends a little bit. And first of all, every lab is different. So, but 500 is pretty high for any lab. Sometimes a blood draw will lead to a falsely high lactate dehydrogenase. If you have a blood draw where the red cells break apart, maybe it's like a traumatic kind of a blood draw, and the red cells are sheared as they come out of the vein and into the needle, that can drive up the LDH number. But lactate dehydrogenase is an enzyme that is often released in patients who have aggressive disease. And so it can be high in aggressive acute leukemia. It can become high in aggressive lymphomas. And it's not really a tumor marker per se, but it's more of an indicator. So if it's persistently high, then you have to ask yourself what's going on. But by itself, it doesn't necessarily mean anything. And I think it's alarming sometimes to our patients. So I have patients who come in sometimes and they've been in remission for years and everything looks fine. But, one day their LDH is high, and often we'll see other things in there that are suggestive of hemolysis. So if your lab drew that and they see that the red cells are broken apart, it would be nice if they would tell you that there's some hemolysis observed.
We have time for one more question.
Sure. And then there's this question: can you give any insight into the process of how lymphoma can develop solid tumors? I'm not sure what that question means. Lymphoma typically is located in lymph node containing areas, although lymphoma can also inhabit the bone marrow. You can have primary bone involvement. You can have primary brain involvement. It can metastasize to the liver or almost any other area. So extranodal spread of lymphoma is, considered to be a high risk feature. And I think you're referring to just the process of lymphoma kind of spreading into other areas. I think that's where that question is coming from.
Thank you so much, Dr. Popplewell, for today's webinar. This was extremely informative. If you can see the chat room, we have included a link to Dr. Popplewell's biography, bio, as well as bios for the rest of her team at the City of Hope Hematology Department. They have teams of specialists in the research and treatment of lymphoma, leukemia, myeloma, as well as benign hematologic conditions. So take a look for those links in the chat room that I've placed there. Thank you so much, Dr. Popplewell, for today. We are so grateful to have hosted this talk. This is also being recorded. We'll be up on our website video library in a couple of weeks. So feel free to share this with your family and friends, and to come back and rewatch it if there's anything you missed or want to hear again.
Great.
We are so grateful for you today.
Thank you very much. And I hope everyone is progressing on their journey and gets all the answers that they need.
Yeah, absolutely. We do as well. And Cancer Support Community is always available to you as well. I will put that website in the chat room as well if anyone wants to check that out. And thank you so much, Dr. Popplewell. We hope to host you again soon.
Thank you. Take care.